Sure. So today,
actually, it's still loading.
Yeah. Okay. No worries.
Okay, now we're live. Now you should tell us about what we're gonna
Today, well, as some of you may or may not have noticed, I put in that we're going to talk about what we did the other day because we went through a lot of discussion in a lot of areas, and I think it's worth going a little more in depth on some of them to see how they tie in. And that's partly because there's more and more evidence that blood clotting is a big, big crisis in this illness. And that's maybe why young people with strokes are turning up at 35. And they didn't realize it initially. They just said, well, how come these strokes are happening? And all of a sudden they're younger, and then they measured their COVID-19 test. And of course, it was positive for COVID-19. And so part of that is the blood clotting issue. And so we're going to talk about blood clotting. And then I've also introduced at the end, I'm going to introduce part of what the next talk will be, and that will be on PLA2.
Okay.
So that's what's found in bee, snake venom, wasps, as well as spiders. Okay. They inject a venom in us, and that changes our PLA2. But we use PLA2 ourselves, but COVID-19 can really trigger a huge problem with PLA2. And this is a lot of tremendous work done by Bill Shaw, Dr. Bill Shaw at Great Plains Labs, but it gives us another place to focus on and even a possible intervention. So there'll be more about that at the end. So anyway, welcome everybody. I'm of course Bill Code, and this is Christina Mitz.
Hi everyone.
And Christina Mitz is a nutrition well-trained and as well extremely competent in the microbiome, and we've spent some time on that. We'll keep going back to it from time to time because it's still really important for our immune system and our general body health.
Wow. Okay. So now that you're introducing this PLA2 thing, it seems like there's a lot of different layers happening with this virus.
Well, it is. I mean, many thousands of people have died around the planet. Just to reassure you to take away some of the fear factor, I think we're finding the death rate is 0.05 to 0.1, and maybe up to 0.2, but it's not very different from a really nasty influenza flu virus. Okay, so just to reassure us on that, and I'm still exceedingly hopeful that British Columbia, where we live, will start to see the same light. I mean, Texas and Florida are about to reopen their beaches and their parks. And I think we should be doing that for people. It really helps people to get out into nature, be well. They can still social distance and do all those components. We have a guide, of course. My wife Denise is a guide. So if I forget my significant pieces, sometimes she'll help fill it in. Anyway, so it's not as huge a crisis. We're learning more and more. So it's an interesting thing, PLA2. So some of you will have heard about it because there's a lipoprotein PLA2, which happens in heart attacks, or signifying you may be increased risk for heart attacks and strokes. But there's other PLA2 molecules in the body, and they're quite dramatic in the lung and the kidney. Consequently, if PLA2 goes awry, all of a sudden now you're at risk. And you may be at risk of a very rough go-around with PLA2. So we'll get into that. So I think the big thing we want to do maybe today is to reiterate and go over what about the blood vessels, because that's right. The common theme in everything else. And so 20% of us will have problems so severe, usually with the lungs, that we're in intensive care. Okay, 20% of those people will have problems with their kidneys. Some of them will end up needing dialysis, and that's one of the crises in New York, because they don't have enough dialysis units. And there's another 20% that may have an increased risk of strokes or more severe strokes. And then there's another subset who have thromboembolism, so pulmonary embolus. For a while, we called it Richard Nixon's disease. You probably don't know that because you're not old enough. But Tricky Dick Nixon had a pulmonary embolus. So for a few years, we called it Nixon's disease. But the pulmonary embolus, of course, means that there's a clot forming in your lower legs or in your pelvis, and then all of a sudden it lost a lot of flow in the lungs. And that explains why some of these people have huge dives in their oxygenation, because pulmonary emboli kill. They always do. So now there's a different concept in treatment. More commonly, when people hit the door of the hospital and they're not doing well, they're measuring their clotting parameters. One of their favorite ones is D-dimer, D-I-M-E-R, because if that is elevated, and it is in a high proportion, those people need extra care and attention because they're going to do problems. So I think they're now starting to look at heparin or low dose, low molecular weight heparin sort of thing. We even use a low molecular weight heparin in pregnancy because many of you may or may not know pregnancy is a hypercoagulable state. And that's nature's way of protecting the mother for small bleeds and so on. And then, of course, at the time of delivery. But with that hypercoagulable state comes some increased risk. So if we concentrate on that a minute, because even when someone comes in with all the symptoms of a heart attack, and they gave a great example online of a 53-year-old woman, had all the symptoms of a heart attack, including the troponin, which is one of the blood parameters, was raised, and they did a cardiac catheterization, normal vessels. Okay, but I want to reassure people it's not as surprising as you might think, because nearly 80% of our heart attacks now, we have normal coronary vessels. That's a big number. And that's because the action's down at the tiny vessels. I've talked about them before, the microvessels, 5 microns to 100 microns, remembering that 100 microns is 0.1 millimeters. So that's really tiny. I can barely handle, the closeness of my fingers to show you. So if you get a small clot forming in the blood vessels down at those small areas, all of a sudden you're getting a group of areas that are short of oxygen. Short of oxygen, mitochondria can't work, we get hypoxia. Hypoxia, big danger. It gives the secondary inflammation spike, and the blood vessels go into injury. So I alluded last time, I started to talk about fibrin, right? Fibrin is little tiny fibers made in the bloodstream system, and they're completely normal. They're happening in all of us. Some of us, i.e. anybody with a chronic illness, and that's nearly 80% of us with illness, it's chronic. So that's things like diabetes, hypertension, MS, history of stroke, ulcerative colitis, Crohn's disease. All of those are spikes in inflammation. Each of those are also have some problems with excess fibrin formation. The excess fibrin tends to coat the lining of the blood vessels. Think of it as sludge lining on the blood vessels. And we know that that reduces the oxygen passing through that blood vessel, because the oxygen has to leave the red blood cell, travel through the liquid of the blood, the plasma, and then through the blood vessel wall. This blood vessel wall is also called the endothelium. So your endothelium becomes thickened, and even a 1 micron, so that's even smaller than I was talking to vessels. Just for a reference point, a red blood cell is 7 microns. It has to squidgy through a 5 micron space, but it can usually. But if you've got a 1 micron thickness of fibrin sludging the inside of your vessels, only 20% of the oxygen passes through.
If you were to have this issue with the fibrin, would it be affecting vessels all over the body, or are there areas? Yeah. Okay, so
it's usually affecting the entire body. And then you as an individual is kind of presupposing where it's going to be a crisis. And so I think that fibrin being present all over the body, the fibrin is increased again when you get an acute infection. So now you're getting COVID-19, maybe you're getting that associated bacterial strain, what, Prevotella,
Mhm.
right? So either one of those, any acute infection dramatically increases the fibrin formed.
Mm.
Okay? So now, if you've got a little bit sludging your vessels already, and you add to that with the acute process, all of a sudden you're extra, extra clottable, hyperclottability. And I think I said last time, 30% of us have a variation in our clotting. 5 to 7% is lack of clotting, or so-called hemophilia, von Willebrand's disease, factor VIII deficiency. But the other 20 to 25% is hyperclottability, and it gets a lot of importance in sway. I even went on a little bit, I talked about MS, and one of the recognized things that can mimic MS is this hyperclottability. And it's called in Britain, because it was discovered there by a Dr. Hughes, a rheumatologist, that some people have a hyperclottability, and in the United States, Canada, they call it antiphospholipid syndrome, but they have excess clottability. And as you can imagine, because I talked about the story of the blood vessels in the brain of a certain long distance away from the heart are the ones that are hypoxic, and they're also the ones that are super at risk in those antiphospholipid people, because effectively they're having miniature strokes.
Mm.
And I would like people to think more of MS as almost like miniature strokes, just as it is in migraine, than any other thing. Certainly more so than autoimmune. I don't like the autoimmune concept. I think we've blown it out of the water for years. Just to reassure you, some of the reasons we do that, the ophthalmologists have been telling us for years that the eyes don't have myelin. Okay, so how do we get a problem with our eyes? Because we get lots of optic neuritis and other problems with our eyes. And that is more likely because of a blood vessel problem, lack of oxygen supply to that region of the eyes, and maybe even the miniature clotting. So the miniature clotting happens in antiphospholipid syndrome, but I would suggest it also happens in a lot of us due to this excess fibrin sludging the inside of the vessel walls.
That's really interesting.
And that's why I came up with that partial suggestion that I think we could benefit our perhaps long-term health, and we might even possibly reduce our risk factors if we hit COVID-19.
Mm-hmm.
So does the fibrin kind of make sense to you? They're little tiny fibrils. They're miniature. And if we, get a break in the vessel, we cut our wrist or whatever happens, all of a sudden the fibrin get very organized, and there's something called thrombin made by the body, and that forms a patch or a clot,
Mm-hmm.
which is what we need to do, or we bleed to death, potentially. So that it's one of the big factors in blood clotting. But if the excess of fibrin is there, and remember, it's in 95% of chronic long-term illnesses, and it also happens in acute blood flow problems, it's probably one of the big factors in Lyme disease.
Right.
Because I know one of the microbiome groups that you tend to see some is Lyme disease, because they have a tremendous penchant or often have needed a lot of antibiotics over time, and so everything's messed up in the microbiome. But if we can improve that fibrin component, often they do better too. And I want people to start at that 100 milligrams. And I'm going to, maybe if you pop out and get Denise, I think it's on the cupboard in the kitchen. People wanted to know the exact type.
Is this the nattokinase again?
Yeah, the nattokinase. So the nattokinase, and someone phoned me, and it was very interesting to get an email request from somebody that I knew back in high school. That's a long time ago for me. I think it's next year, 2001, will be my 50-year medical reunion. 2021, sorry. So nattokinase, and the one that's approved by the Health Canada, at least one of the ones, and that's why it's got the Canadian flag on it, and it has an NPN number, okay? So if you copy down the NPN number, 80089299. So it's 8-digit number. And the natural product number, or NPN number, is what is replaced in Canada the DIN number, drug identification number, which is all of our over-the-counter products. So we've got some questions starting to turn up.
Let's see. CBC News did a story on the cytokine storm in COVID. ME and CFS also have cytokine issues. ME and CFS have red blood cell deformability issues where the red blood cells can't go through the smallest capillaries. Is there any evidence of lack of red blood cell deformability in COVID, and could that cause blood clots?
So it's a good question, but there isn't any recognized blood cell deformability or abnormal formation. I mean, the common ones we talk about clinically are sickle cell disease, okay, because they get a different shape of their red blood cell. And that's more common in people that have had to survive malaria over the years. So it's more common in the blacks from Africa, of course. And then we've got some of the other variations in how the red cells form. But this is not one of the ones that trigger that. And the other one, just for interest, because I don't think it creates a deformability. I'm not aware that it's a problem, but lack of B12 is a problem because you get a very large red cell, okay? And it doesn't have the ordinary elliptic type shape. So I don't think it's a factor, but you're completely correct about the cytokine storm. The body uses cytokines. It's part of our inflammation process. It's part of how we heal. It's a completely normal phenomena. We just don't want it to be off the rails.
Right.
And really peaking. And that's why if we can calm it down, then we can calm down the ulcerative colitis or the Crohn's or the MS. Everybody agrees MS is an excess amount of inflammation within the brain and a leaky blood-brain barrier, and they tend to go together.
Right.
And my favorite thing about them, of course, is the hypoxia. So lots written about it in the book, and also a whole major chapter on mitochondrial dysfunction. Now, we're not going to talk much about that here, but I wanted to reiterate. So we gave you the name of the nattokinase, and that's the main one to start. And it's probably wise to only start with one a day. Okay. It tends to be a slow release type, so that smooths it out. If it was on its own, it would last 8 to 10 hours for a half-life, and so you'd have a modest amount still over 24. Some people, if we're treating chronic Lyme or chronic mold problems, we sometimes have to keep bumping that up. But start low, because as you release that fibrin, it causes changes throughout the body, and you may go through so-called Herxheimer, or a reaction which is unpleasant. Okay? Start slow, creep it up maybe every 2 weeks to maybe up to 2 twice a day. So that will, make a huge reduction in risk from that. So remember, ideally, when someone is possibly going to have MS, someone's going to really carefully check their clotability to make sure they don't have antiphospholipid syndrome and they don't have some of the other problems. Some of you will have heard of people either during pregnancy or before their diagnosis of their cancer. Good friend of mine, she had a blood clot in her leg flying from Vancouver to Toronto. She found out after that it was probably triggered by the hyperclotability of a breast cancer. Okay? So she went on, had treatment, and did really well, but her first sign was hyperclotability. And if you're really unlucky with that hyperclotability, it's a problem. So sitting in one place a long time, I hope everybody's exercising and moving around. We should get up once or twice when we're doing this to make our blood pump a little better. But it really makes a huge difference moving the blood around. And the other group that's super high in this group, as you may or may not have heard, is after somebody's had a major orthopedic procedure. So a hip replacement, a knee replacement, even to some degree a shoulder replacement, but especially the lower limbs, then they're hyperclotable. And that's why they're put on low molecular weight heparin or some other variation of heparin or some other blood thinner for that first several months after the procedure.
Would you ever use heparin just for like an MS diagnosis?
No, you would not, but we tend to put them on one of these long-acting drugs. We used to only use warfarin, which I didn't like, because warfarin stood for Wisconsin Agricultural Research Foundation, because it was developed to kill rats, of course, as a rat poison. And mostly we moved on from warfarin now because warfarin is a vitamin K poison. It wipes out vitamin K for all of its important deals to us. Vitamin K is a really part of the vitamin D, magnesium,
Calcium.
and calcium system, not with just regard to bones, but a whole lot of other functions in the body. And vitamin K2 and is also important. In fact, newborns are given an injection of vitamin K for that risk factor of not enough clotability. So I think if we take those different pieces, let's see, I'll let you keep an eye on it if we're getting more questions. I'm hoping that people can understand it. It will likely help the health of your vessels and reduce the likelihood of a thromboembolism. What I was also talking about, some people go on the oral contraceptive pill and then all of a sudden they have a blood clot. These people are probably one of the variable groups that genetically, because it tends to happen in families, and they have hyperclotability. And some of them will, of course, be on a 3-month at least blood thinner for the lower legs, but if it keeps recurring severely, and they're going to flare anytime you change the estrogen progesterone a lot, and you're changing that a fair amount with oral contraceptive pills, and of course you're changing it with pregnancy, because that's where the risk. And if we're going to talk about pregnancy, just to reiterate that, other clues that you may be hyperclotable is if you've had repeated spontaneous abortions or miscarriages. That's high risk. That may have happened due to clotting inside the womb and you lose the baby. The other people that we're noting that it makes a difference to are the ones that have sometimes premature delivery or hypertension during pregnancy, or so-called toxemia. And each of those, if we've got the clotting optimized, then those tend to not happen near as much.
Okay, and then technically you might say that they would be more resilient in the face of COVID-19.
That's right.
Okay.
I can say that it's likely to improve your long-term health and well-being. I can't confirm, but it makes sense to me, and I'll be honest, I take it daily myself for that simple reason. Plus, I think it reduces mine. So a simple test that a lot of us can do, and I did this again, of course, when I did one of the Great Plains lab tests where you poke yourself in the finger and then you bleed it onto a blood spot. Well, mine clots too fast. So it's a hassle. You got to make a fairly big hole, get out this blood. But I've seen it happen with several friends. Often they have MS, and I think they're often hyperclotable.
Right.
So hyperclotability is not a good idea. The other important thing, I think I mentioned it in the past before, but there's a major significant crossover between having cardiovascular disease and having MS. Meaning if you have MS, and admittedly it's mostly women, 3 to 1, but you have an increased risk of heart disease, stroke, and all the blood vessel issue problems. And so that's why, they fit together a lot. I think the other reason that they fit together, often you've got that variation perhaps of fibrin in those tiny vessels. So it doesn't just affect the tiny vessels in the brain, but the tiny vessels in the heart. And they're the ones that are critical for supplying the blood flow and the secondary oxygen availability to keep those tissues healthy. And that's why there's a crossover in those groups of diseases, I would suggest.
Interesting.
Yeah.
Well, we do have a question from Jody. She says, I've had more trouble with my MS in the last few years. I exercise and eat a healthy diet. Lately, I've had very shaky hands, and occasionally my legs shake when I stand. My walking looks like I'm drunk. What suggestions do you have to help these problems?
Sure. So, there's several chapters alluding to MS because it's one of the reasons I wrote Solving the Brain Puzzle. I don't know if we've got that showing up there today. There it is. Okay. And I'm going to talk about the bear up there too. Eventually, if I forget, remind me, please. So the feature in MS, the one that I've added in, Jody, in the last 5 years is I've done over 500 hyperbaric oxygen treatments. Why? Because remember, the part that's getting injured in the brain is right at the end of a very long tract of blood vessels, initially arteries, miniature arteries, capillaries, and then veins. But at the longer the road, of course, the more oxygen that's being picked off from the hemoglobin on the way down the road. And that's why it's really short at the end. So one option is to increase the blood flow, and it's possible the fibrin may help you with that by taking the nattokinase to take away those fibrin components. But the other one is to add more oxygen at the front end. And that's why when I sleep at night now, I use oxygen concentrator 2 to 3 liters per minute in the nasal prongs, or I use a pillow variation thereof. But that, I think, makes a difference because often our oxygen drops at night. The other thing I think that happens a bit over time, I think you're probably younger than this, Jody, but as women reach menopause, they become somewhat more at risk of the cardiac issues. All right. And so that's why I see some of my friends, their MS aggravates when they hit menopause. Okay. Puts them in that same group. So the other option, if you can't get access to a hyperbaric oxygen treatment unit, then it's buying an oxygen concentrator, sitting an hour a day at least, or a half an hour a day, or even better yet, while you're exercising. So you're using a particular mask, and so you're giving that boost of oxygen a day. It sounds like, well, how could an hour make a difference for the whole day? Well, it'll interest you to know that teenagers, if they put on one of those good-fitting masks in a non-rebreathing bag for 1 minute, their brain works better for 24 hours.
Wow.
So I'm not a teenager anymore. You're closer. But it's dramatic how much it can make. And if you're doing that hour a day, and that hour has the other parallel I talked a bit about was in treating cluster headache, which is 3 days of migraine, and probably also in migraine headache too. Often that boost of oxygen at 5 or 10 liters a minute flow rate with a good non-rebreathing bag, and I'll show a diagram another time, but really boost that oxygen up. And it seems to be effective. And the reason it's effective is you can boost the oxygen up. You can be epigenetic or helpful in turning on up to 8,000 of your genes. Mm-hmm. Turning good ones on and not so good ones off. 8,000 is a lot. I mean, it's 2,000 to 3,000 for vitamin D. You know, the only thing that's bigger than that is the microbiome, because it's probably in the 20,000 range. So that's why all these little pieces matter. And so, you know, those are some of the pieces that, you know, you could adapt or add into your current system. And if that isn't enough, then some people will still, you know, contact me at info@drbillcode.com and consider a consultation, because there's composite of things to do. And I talk about them in the book, you know, how to change your microbiome if it's been unwell and all these other pieces. So it's a complicated answer for a lot of things. I wanted to talk about the bear. So you can see the little bear up there beside my book. The bear has a Canada flag on his chest, and he's got a Mountie hat. And it's important to me because that was given to my mom a few years ago. It was a very special bear for her. She loved teddy bears at the best of times. We lost Mom just over a year ago, and the 23rd of April is her birthday. Mm-hmm. She was born in 1926, so she would have been 94 today. She died just before her 93rd birthday. But a great inspiration to me. It's also the day, interestingly enough, of Shakespeare's birthday, 23rd of April. And it always gave Mom great pride because she was 2 days younger than the Queen, because the Queen turned 2 days ago, 94. So it's good to have the continuity. It's also good to have joy and laughter. So if some of you are interested, you can go to the podcast I did with Point of Return yesterday, and we did it on the value of laughter. And we talked about Norman Cousins and his controlling his ankylosing spondylitis by more laughter. He would watch the Three Stooges and the Marx Brothers and just do much more laughter. And it took him from nearly immobile and told he had a few months to live till he lived over 25 years.
That's amazing. And I can tie that into the microbiome as well. So there are certain species of microbes that respond to the neurotransmitters that are released when we laugh and are happy.
Not only that, laughter is interesting because it dramatically enhances blood flow. I'm nuts about blood flow. I get that. But it enhances blood flow, and it does a really good job of an oxygenation improvement, so the deep belly laughs. In fact, it can even be faked, as in, I guess, laughter yoga, because I don't think you do it with jokes. Although, I mean, it'd be one option. But laughter yoga has definitely been confirmed and shown physiologically to make a big difference in blood flow, oxygenation, and healing.
Amazing.
Yeah. If we do those healing, it helps all of our healing pieces. And maybe if we have full-on COVID-19, and we shouldn't be underestimated. Keep people cheery.
Right. Well, we have a couple more questions. Roger is asking, is there any danger of using too much flow, say 5 LPM instead of 2 LPM with the right time oxygen concentrator?
Oh, LPM, liters per minute. No, there's not. Okay. There was a myth a long time ago in the chronic obstructive pulmonary disease patients that if they breathe too much oxygen, they would quit breathing because they've lost their CO2 raised, being their oxygen drive or breathing drive, and it turns over to oxygen. Most of those myths have been blown out of the water. For a healthy person, whether it's 2 liters or 5 liters, not a problem. You will find 5 liters feels like a wind tunnel.
Okay.
And one of the treatment modalities they showed in the New England Journal just in the last year or so was that you can even turn this up to 50 liters a minute. Okay. And it's a bit like a miniature ventilator or a high frequency jet ventilator equivalent when you're doing that, because it's the turbulence is probably making the difference for the increased oxygenation. So there's not really a risk whether you're doing 2 or 5. You're going to need to do more if you're going to be on a non-rebreathing mask or if you're going to be exercising with it. When I use a non-rebreathing mask for exercise, I run it at 10 or 12 liters per minute.
Right.
Because you need more of that. And remember, exercise increases flow. You boost the oxygen while you do the exercise, you get a double win-win.
Right. Let's see. Roger is saying the non-rebreathing mask has valves, right? I have a mask with the bag without the valves. What is the percentage oxygen difference between the two?
Well, yeah, there's naturally valves in the non-rebreathing mask. If the mask has holes in it up at the top, you're not going to be able to let it function as a non-rebreathing mask because gases will go in and out through those holes in the mask. And they're put there for a specific reason so that there isn't an excess amount of oxygen. Okay. So you're either going, and it must have one of these, looks like a plastic bag connected to it, because as the tubing brings down the 5 liters per minute, while you're breathing out, it's going into that reservoir bag. And then there's some there, and there's some coming through the tubing, because you breathe in faster, closer to 10 liters per minute breathing in, because you've got big tubes to breathe it in through. And that's where your bonus extra boost in oxygen. So if it's got holes in the mask, you're going to have to cover those over and make sure that everything else still works. So good questions, and probably a little complicated. I know Roger a little bit, and he's got expertise to ask people. So you need to find someone who knows what they're doing if you're not comfortable with that. And so sometimes that's a person who runs a hyperbaric chamber. Sometimes that's a respiratory tech because they're treating sleep apnea. And we haven't talked about sleep apnea for a while, but those of you with sleep apnea would already have a CPAP machine. You will probably do better with COVID by having that because it helps keep those airways open.
Right.
But at the same time, I would like you to do the other components so that you can breathe well and do well.
Well, some other folks who seem to know a fair bit about the oxygen, at least in our area, are the red light therapy folks. I don't know if it's commonplace for the laser companies to be pairing oxygen with the laser, but certainly The company that does it here, they're really knowledgeable as well.
They do, and they've been very enthusiastic on that, which is great because we do know that photobiomodulation, which you're describing in short term as red light therapy, photobiomodulation, because we are light beings, and that's why time in the sunshine is extra good. Not just the vitamin D, but probably the light itself. When we're going into this, it will penetrate even through the body partway. If you're doing a laser, you can get up to 2 to 3 centimeters potentially penetration. And when it's doing that, it's acting on the mitochondria, so-called cytochrome. So there's that light sound, cell light. And it is releasing nitric oxide from those bound and allows more oxygen to happen. So if you add to it some oxygen that you're breathing, you have a relative win-win of improving the function of those mitochondria. And that's why it's a very useful thing for someone with, chronic fatigue syndrome, fibromyalgia, on all those groups. So those also will benefit by repeated treatments of that to get it better.
Right.
Yeah.
Carla wants to know, or no, it's Shelley, where can we buy the rebreathing oxygen mask?
Well, you can buy some of these things online. If you go to Sleep A, a very Canadian sounding company, sleepa.ca. So that's one of the places that have it, and they have a oxygen, non-rebreathing mask. And there's quite a group of people. If you need expertise, ask someone in your local area. Respiratory techs are a good place to start. Anesthesiologists are a pretty knowledgeable group on it. You won't get very good knowledge about it from our regular family medicine people or even internists and so on, because mostly they're anxious and fearful about oxygen. We've raised a whole generation of fearful of a little bit of extra oxygen, but it's a very safe thing to do in almost all cases. So, you can access it in that sort of format, and, you should be able to find someone who can help you through it. Barring that, you can contact myself, and we could list them online, but it's important enough that you get a knowledgeable person rather than just give up on it, because it's got a lot of value for you long term. We haven't talked about Alzheimer's yet, but oxygenation and blood flow are the early start of Alzheimer's. 20 and 30 years before, you're getting into huge problems. So it matters. So I think with what we've got there, I wanted to go on and talk a little bit about PLA2, okay? So PL phospholipase, okay? It sounds a little bit like soap, and that's a good term to remember, because when this is overactive in the body, it's acting as a super powerful detergent, and it's changing how things work. And we know that the COVID-19 virus acts on the cells, particularly on the lung cells, and will dramatically raise PLA2. So there's a group that have raised PLA2 already. So they are ones that should pay particular attention to this, because they may be more at risk. We know that the PLA2 is raised in chronic lung disease. It's raised in ulcerative colitis, Crohn's disease, major recurrent allergies, because that affects the lungs, right?
So asthma?
Asthma, not as much, but it is possible.
Okay.
Yeah. And MS. Okay. So there's that whole group, and diabetics. So diabetics is a red letter one for you, for the simple reason insulin, we always think of it as controlling sugar entry into the cell, okay, or glucose entry into the cell. But it also has a controlling effect on excess PLA2.
Interesting. Okay.
And it's now recognized that diabetic ketoacidosis, which is a life-threatening medical emergency, it didn't ever seem to make very much sense to us. This person over here would have a really high sugar, no problem with diabetic ketoacidosis. The one over here has maybe not even as high as sugar, they've got diabetic ketoacidosis, and they're in a risky, life-threatening scenario. And now we know that the one who's getting diabetic ketoacidosis has the elevated PLA2.
Okay.
So the world expert on this, I would have to suggest, is Dr. Bill Shaw of Great Plains Labs. So anybody that wants to go to greatplainslaboratories.com, you can even look at a webinar, 2 webinars now in PLA2. I watched the second one last night, but he's been measuring it for quite a number of years. In fact, we did a study together here on Vancouver Island of people with MS, and they had raised PLA2. We didn't publish the data, but there's other people published similar data on MS. The higher the PLA2, the more rapidly progressive your MS.
Mm-hmm.
Okay? So this might be something that, to go back to Jody's question about the MS, you can get your PLA2 measured. They take 10 cc's of urine first thing in the morning, and of course you send it down to Great Plains Labs. You have to arrange ahead of time so that the shipping's looked after because it's down in Kansas. But the raised PLA2, because we have a relevant antidote, something called citicoline, CITICHOLINE, or CDP choline. And I do that in extra careful writing because phosphatidylcholine, which a lot of us think of as a supplement to maybe be helpful, it can add to the fire of excess PLA2. So do not take extra phosphatidylcholine at this time. If you've got a raised PLA2, you want CDP choline. So this is available over the counter in health food stores, Canada, United States. In Europe, it tends to have been treated like a drug, citicoline, but they decided when they marketed it over here, I guess there wasn't enough money in it for the big pharma boys. So they all of a sudden, it's become a natural health supplement. And I looked it up today online, and Jarrow, JARROW, is available here in Canada, and one could take that. The baseline dose, and he talks about this in his webinar as well, the baseline dose to just be preventive and well is 1 capsule per day, and that's 250 milligrams. But if you're having Alzheimer's or you're worried about your COVID-19 flaring and you want to help it, then you would do 8 of those a day. So you do 250 milligrams, maybe 2 of them, 4 times a day. Okay? So that will dramatically calm down the PLA2. And it's a great thing to learn about because maybe that's someone that are, colleagues or associates or clients with ulcerative colitis, Crohn's, certainly MS, may be able to really help those. And I think the really important group that should be looking for this is diabetes, because we want to be out in front. We know that diabetes and obesity are both super risk factors for COVID-19. And this is one way I think also you could stay ahead of the curve.
Great.
Okay. So CDP choline, PLA2. So just to go over that again a little bit, your family doctor and certainly your cardiologist will know about lipoprotein PLA2. So this is a bigger molecule because it's got a lipoprotein attached to it and then the smaller PLA2 to it. So you can only measure that in the blood, but that's predictive of increased cardiac risk factors, okay, and stroke risk factors. Meanwhile, the smaller molecules of PLA2 in their own, as they're produced in the lung in COVID-19 and in other parts of the body, are small, and they are filtered very quickly by the kidney, so measuring them in the urine. And of course, as he explained well last night, measurement on the urine or blood spot test these days is a lot easier because all of our laboratories, especially our laboratories in hospital, if we need to do a blood draw, it's a big deal. Everybody's really busy. They're not interested in doing something that they don't know about. Mm-hmm. So fair enough. But PLA2, you can measure on the urine.
Well, I'm wondering, so because it responds to the citicoline, does the citicoline influence bile output? Because it's got choline in it?
I don't know.
Okay, and then
that's a good question, though. I see what you're thinking in the pathway. I mean, bile is a complicated thing to form, but it's incredibly important in fat digestion and other things. I don't know the answer, but I'll look it up.
Yeah, I'm just
See
wondering
if we
about the
can find out.
mechanism of action and if it has something to do with the bile. But yeah, I guess we have more to learn.
Yeah, so the PLA2 we will try and stock, but remember, when does it go up high? It goes up high, a bee sting, wasp sting, snake bite, it kills people
Mm-hmm.
sometimes. And that's because it often causes that huge clotting, clotability, and the vessels jam up. So we're back to some of those flow issues. So this is something you can get measured to find out. And I know already Dr. Shaw is keen to try this out on seniors because we know with PLA2 in the lungs, if you're a young child, almost no PLA2 is released when you have COVID-19.
Hmm.
Every decade older, the more that's produced.
Okay, there we go.
So this is pretty interesting because this may explain a lot about why the elderly seem to be more at risk
Mm-hmm.
of a tough illness and maybe even a lethal illness.
Mm-hmm.
So as we continue to do things, I mean, one advantage, we've got the world very connected. There's lots of these articles come out even pre-peer review, and then they get peer reviewed over time. Because ordinarily, to get a journal article published, it takes 6-12 months, okay, between all the differences. And excuse me, everybody wants to shorten that up right now because of all the gravity and concern about things.
Mm-hmm. Well, we do have some more questions. One question, if you start using an oxygen concentrator, do you need to start using it slowly? And also, do you need to wean off of it slowly?
Yeah. Well, the good news is you don't have to wean off it, okay? You don't get addicted to oxygen. There's not many people addicted to oxygen around them, although if you've been up at a really high level, we were up nearly 2 miles at Cusco in Peru, which is, the kind of the jumping off point to Machu Picchu, which is actually lower than Cusco. Cusco's 11,000 feet or roughly 2 miles. I can't convert it in meters, but maybe you can do that for me. So anyway, but you go down and say, wow, it's nice to breathe oxygen again. There's still 20% oxygen up there at 11,000 feet or on the top of Mount Everest. There's still 20% oxygen, but there's a lot less molecules because everything is more sparse because it isn't as concentrated. Mm-hmm. And there's less molecules of oxygen and nitrogen. And therefore, it's still 20% oxygen. That's kind of a trick question, but it isn't enough to breathe easily. And you can't predict, it's a bit like COVID-19 in that, you can't predict who's going to get hypoxic injury. The headaches, the vomiting, and being very unwell, because it sometimes happens in young people too. Mm-hmm. So does that answer what they were trying to figure out?
The question, do you have to...
Do you have to taper onto it slowly? No, you don't need to taper onto the use of it usually either, okay? I would suggest, if you're not sure how to use it, do yourself, spend $50 to $100 on a pulse oximeter and learn what your personal baseline is when you're sitting or standing. What is your personal baseline when you're laying flat? Because most of us sleep laying flat, and that compromises. Usually it goes down a couple points, sometimes more, all right, just because of the weight of the contents messing up our ventilation and perfusion in the lungs, okay? And then you know where to do it. So, and if you put on your oxygen and now you're up at 98, that's probably good. You don't have to get to 100%, all right? Some of us will. I mean, I put it on one of our young friends the other day, and she was 98, 99. So that's all good. That's very well enough. I'm talking about the people that need it for a specific issue in their body that they would benefit from more oxygen. We do know that extra oxygen of a larger amount in the hyperbaric oxygen unit, sure, it will turn down inflammation. It will give you a stem cell boost of 6 to 8 times your own personal stem cells in 20 or so treatments, and 40 treatments will help create new blood vessels in the body, and they're created where they're needed. So that's the extreme. On the way up there with the oxygen concentrator, you will find if you're carefully watching, when we have a very low pressure system, so that might precede a storm, an entity, that can be up to a 5 or 10% change in the pressure of oxygen.
Mm.
That is when the people with lung disease and these other troubles flare. And even I've seen MS people flare. When the barometric pressure falls, it's a bit like going up partway to Cusco.
Mm.
Okay? There's less oxygen molecules. And if you happen to have a piece of your brain that's quite borderline for function, all of a sudden it doesn't have enough. And remember that neurons don't die, but they go to sleep or they idle. So if you can bring them back up with oxygen, and that's why I recommend the 2 to 3 liters at night. The other group I recommend highly to it tonight or at night would be the obese and anybody with sleep apnea. Because I have learned through hard discussion with patients, people that are given a sleep apnea device, a CPAP machine, half to 2/3 quit using it in a year or two.
Mm-hmm.
So if you're not going to use it, for crying out loud, at least use the oxygen, 2 to 3 liters per minute. And
Right.
the only key thing is take it off before you get up at night to go to the bathroom.
Right.
Or pulls your neck back.
So if we have a chronic illness or inflammation-related illness, which is all illness, we're using the oxygen, we have our pulse oximeter, and it reaches 99, 100%, to just keep going and keep it at 100% or keep it as high as we can for as long.
If you want to be really careful about it, you could, don't use any more than 98.
Okay.
Okay? So that gives you an indicator to drop in. The other advantage of buying that pulse oximeter is because some people go awry. And I think I mentioned before, there was a situational representation by the WHO in early mid-March saying that people need to have oxygen availability and they need to have pulse oximeters to see how they're doing with their COVID risk. And are they getting to a stage where they got to go to hospital? Mm-hmm. So if you're at home and you've got a pulse oximeter and now it's dropped 5 points, get your oxygen on, bring it up, and start with the nasal prongs. That may be enough. That's often all they're using in a hospital. Right. When people are in hospital is nasal prongs oxygen. So, and if you don't have that, fine. Head to hospital, tell them what your pulse oximeter is, and everybody will get pretty interested in you right away. And ideally, they would do your blood test and maybe think about putting you on something like low molecular weight heparin and all these other rescues to reduce the cascade of problems, whether it's kidney problems, liver problems, brain problems, or lung, of course.
Okay, great. We have a couple more comments and questions. So Roger says for the Vancouver viewers, he was able to get citicoline at Cripps Pharmacy in Vancouver. He didn't necessarily improve on it, but he was able to get bulk powder D-ribose, which helped with his ME and CFS.
Yeah. So D-ribose is one of my 3 favorite mitochondrial kickstart products. Okay, talked a bit about it before. I learned these from Dr. Mark Houston, who's a brilliant cardiologist out of Tennessee. And he was able to get 4 people off the heart transplant list by giving them D-ribose, and it's a powder, and it's 5 grams 3 times a day. Mm-hmm. And then the other part is coenzyme Q10, which you all know, 200 milligrams 3 times a day. And I think that's not a bad idea. I'm taking that mostly right now because of the antioxidant capabilities for it, trying to stay well in the COVID time. And then the third one is carnitine. So that sounds like carnivore. And it's made from a meat product. And if it's a brain issue you're thinking about, then buy acetyl, A-C-E-T-Y-L, acetylcarnitine. And that dose is 500 milligrams 3 times a day. All of those are available over the counter and could make a real help. And the people that get a boost out of D-ribose, often 20 minutes after taking it, they feel a perk in energy, which is a wonderful thing when you're not much in energy.
Right. Those 3 are strongly recommended for the autism group as well.
Yeah, and it's and they're one of the mainstays because I've got the whole major chapter on mitochondria in solving the brain puzzle, because that's a very useful piece for almost all of us.
Right.
Sometimes there's a little crossover with other things, but those we can control because it's really hard to get into exercise or all of these things that take a fair bit of energy if you can't get off the pillow.
Mm-hmm.
I'm very sympathetic with that because 85% of people with MS have low energy. I've met a couple, no problem with their energy, but it's pretty uncommon.
Yeah. Another comment, I find I get bad migraines as the barometric pressure starts rising from a deep low, and the pain was even recorded on my Loretta QEEG during a neurofeedback session. Why the delay?
Well, it takes a while. What happens with a migraine is we get the trigeminal nerve and the distribution of it goes through what we call a depolarization. But it takes often several hours for all that to transpire. And that's why sometimes we get benefit with the sumatriptan, and sometimes we can also break that cycle with the boost in oxygen. And if you're getting the change in the barometric pressure change, it's because of that significant change. Because it's an interesting point, and you make it pretty well in how you tell the story. It's one thing to lower the oxygen, okay? So you can lower the oxygen and you might cope during that time frame. As soon as the oxygen comes back up and increases in the area, now you may be getting cytokine or inflammatory molecules occurring because now you're getting the free oxygen radicals increasing. So it isn't due to oxygen toxicity, but it's due to the body's ability to recover and start to recover from the low time, which happened at the bottom of barometric pressure. And now it takes a lag time to reintroduce oxygen, and the body goes through that healing process. And this is why there's often confusion. Oxygen is toxic. It's not. It's never, ever toxic in that kind of format. But it's the change when you're short of oxygen and then it comes back up. This is nowhere better seen than someone who have their carotid clamped and they're having carotid artery surgery, or maybe they're having heart arrhythmias and they're reperfusing the heart. All of these change times are higher at risk because of that recovery time. The oxygen goes back up. All of a sudden, the areas that were short before flare with reactive oxygen species or free radicals.
Okay.
Yeah. Good question. What else have we got there?
Warren says, I haven't heard my heartbeat in my ears for about 6 years.
I think that's a good thing that you're saying. And I get that. It's possible, two things are possible. Now, the flow is maybe somewhat reduced to that ear due to atherosclerotic changes. That's one possibility, because it'd be interesting to see what your blood pressure is doing and your pulse rate. And then the other possibility is that now you've got enough better flow and healing so that you're not getting that dramatic piece. And, you know, it's an interesting piece that fits in, and we see it lots in MS too, because people with MS often have that pulse in their ear. They have their balance canal problems, because remember, the ear is important for balance as well as hearing. And some of them even have a hearing problem, okay, due to the MS. And remember, the MS is lack of oxygen in those key focused areas. Because the ear hearing and the balance, very much like the eyes or other neurons in the brain, are very energy hungry. They need a large amount to function optimally. And that large amount means a lot of oxygen flow from the blood flow, and it means that the other mitochondria are working well. But the biggest rate limiting step is usually the lack of oxygen.
Okay. Well, it is 1:57, so maybe we should wrap things up and we can just kind of go over what we talked about.
Sure. So today we wanted to reiterate, talk about some of the issues with oxygen with regard to COVID-19, because I think it's starting to help us understand why do people get 4 or 5 different major problems, almost 20% each. And I think the common theme is, where is that individual's relative weakness? One of my relative weaknesses is my brain. Another one is my kidneys, unfortunately. So it's a matter of finding out, where are you in that continuum? Some of us will know, Some of us won't know. Diabetics, they're going to know that maybe their kidneys are at risk, maybe their heart's at risk, and maybe their brain's at risk, all because of the blood flow issues that happen with diabetes. So try to move on from there and then talk again about that fibrin component and how we might minimize our excess fibrin component, because we may well have it because of our current chronic illness, and take away that fibrin excess so that when we hit the door of the hospital because we've got full-blown COVID-19 problems, we're that 1 in 5, okay? So then maybe we're not going to have as much a crisis as we go through. And then we tried to talk about PLA2, phospholipase 2. And we'll put the links in to Dr. Shaw's webinar. He's got two. The first one's pretty complicated, but have at her. But it'll be fabulous for the practitioners that are watching. They'll get a great deal out of it. The naturopaths, physicians, osteopaths, chiropractors, and so on, and anybody that's really into the physiology stuff. It'll make a real difference. So the PLA2, we will use it as an intro to next time, because we're going to talk more about PLA2, because you'll have a chance to read about it, learn about it, see if you can get some of the citicoline or CDP choline. And then I think next time we'll also talk some about glyphosate or Roundup. It's one of my pet peeves. It's not accidental. I've got mentioned 2 or 3 times in the book in important areas. But Dean, who of course was, doing as my co-chair when we started doing these about a month ago, he's finally got his results back. I checked with him. He's okay. I mentioned it. His glyphosate was about 97 percentile.
Right.
It's the highest I've seen. I did see a child under 6 in Regina, Saskatchewan in the Midwest, and he was 95 percentile, but we'll talk about why that wouldn't be ideal.
Right.
And it really puts our microbiome at risk, which puts lots of other things at risk. And so we'll talk about that in considerable detail next time. I'm not sure to go entirely on the concept of, the biofuels are triggering the problem areas from the airplanes using it, but, it's one of the things suggested in the current day. So we'll focus on that particular things. And so what we're trying to do, how can we optimize our health for improving our risk with COVID-19, but also how we can improve our longevity and well-being ongoing, because we're going to get past this COVID-19 crisis. Sooner the better, I think. They'll be kind of loosen things up. That's my personal opinion. But, why not take advantage of this as our reset time? This is our opportunity to optimize our health. We've got more time than we've ever had. And that's why I really appreciate you folks turning up for these, because it's time to empower yourself, honor yourself to look after your health. Whether you're a parent or a child or a grandparent, quality of life is in your own hands.
Exactly. Okay, well, thanks so much, everyone, for watching. We will make sure that the replay is available both left on this Facebook page and also on the drbillcode.com website. So if you know anyone who's not able to watch this on Facebook, you can definitely share the link to the website. Okay, see you Tuesday.